amazing speakers. They're going to review a paper each that they have put together for our hopefully understanding. And they're going to speak for about 20 minutes apiece. We'll take one or two questions at the end of each of those, but I think that the subsequent presentations may spark additional questions for earlier speakers. So at the very end, we'll spend 15 or 20 minutes with all three of our speakers interacting with you, fielding questions. Because we want to record these question and answer sessions, we would ask if you have a question to please go to the microphone so that can be recorded by Ancient Faith Radio, so that it makes sense when people are listening online what the speaker is answering, what the question was to start. So I think with that, I've got precisely 1 o'clock. We'll get started. Our first speaker in session 5 here is Dean Theodore Saklarides, who is Vice Chair of Surgery at Rush and hails from this parish, and he is going to speak to us about delivering bad news.
Thank you very much. I'm humbled to be here in view of the talents of my co-speakers and the rest of the program. I've been in practice for 31 years at Rush University here in Chicago. I was also ordained to be a deacon in this parish 4.5 years ago. So my first comments are Christ is in our midst. So let's begin by asking ourselves, what do we know? True or false, communication skills can be taught and retained. They can be taught. Whether they're retained or not is another question. There is a paucity of studies looking at the long-term results of training programs. True or false, surgeons are frequently the ones breaking bad news. True. Surgeons are the most effective in breaking bad news. It's about as false as you can be. Over the phone or in the recovery room is a good place to deliver bad news. False. Surgeons typically spend an hour for delivering bad news. Way false. Inexperience in breaking bad news can contribute to your stress. Definitely true. Not every disease is curable, but every disease is treatable. True. Even aspirin is treatment, and it fosters hope. Never say, there's nothing more we can do for you. True or false, your faith can enhance your communication skills. Absolutely, and I will spend time with that. My personal feelings are that technology has really affected our ability to communicate. And this is influenced by time constraints, productivity requirements. We're always concerned about being on time. And I got an email the other day that I won some kind of award because my patients spend the least amount of time waiting in the lobby and the least amount of time in the exam rooms before I walk in. And I'm going, who keeps track of that? I mean, it's amazing what people keep track of and how you are graded. So in light of those constraints, I think it has affected our ability to communicate. We've gotten lazy. We've become cold and sterile. We've become efficient, but are we communicating better? Now, one of my personal heroes is this man, our 16th president, Abraham Lincoln, who was an amazing communicator. And I'm not going to read the Gettysburg Address, although I have it here. But the interesting thing about the Gettysburg Address, the Battle of Gettysburg was fought in July of 1863. And a few weeks after that, they commemorated the battlefield with this big ceremony, and politicians were there. And the interesting story is that some of the speeches were an hour long, and it was in the summer. It was hot, people were sweating, and here comes Abraham Lincoln to deliver his Gettysburg Address that lasted all of about 2 minutes and 30 seconds, but we remember it to this day. We don't remember the hour-long speeches, but people were just getting their popcorn and their Coke, but by the time they came back to their seat to sit down, the Gettysburg Address was over. So it doesn't have to be long to be an efficient and communicative speech. My first exposure to giving bad news was in the early 90s. I was a young attending. I was about 2 years out of my fellowship. And the picture on the left is Harold Washington, the first African-American mayor of Chicago. He died in office, and he was succeeded by this gentleman, Eugene Sawyer, a gentleman, very mild-mannered, meek, soft-spoken, and his 90-year-old mother, who lived in Alabama or Mississippi, was diagnosed with colon cancer. He brought her up to Chicago for her surgery. I was her surgeon, and we did the operation, and as we're closing the abdomen, she codes. She goes into full cardiac arrest. And I didn't know how to handle the situation, so I called my chairman at the time, who just happened also to be my father-in-law, Stephen Economo, and I told him what's going on, and he said, okay, and this is the value of mentorship, I think, in your practice. He said, bring the family up to the surgical library, which is a very private area, bookshelves, walnut panels, carpeting, very subdued. Bring them up there and tell them she's not doing well, that we're working on her. So what he taught me in that little advice was pick a private place to deliver bad news and do what's called fire a warning shot. In other words, tell the patient or the family what's coming, but maybe don't give full disclosure right at that minute. That warning shot allows them to prepare emotionally for bad news. So I did that. The patient expired. I came back up to the library and told them, and that was my first exposure to how to deliver bad news. So what is important? I think what's important is to imagine you are the patient and how would you like to hear the bad news? It's not going down. Okay, so how do we communicate today? Email, texting, Facebook, Twittering, Googling. I mean, those weren't even words 20 years ago, right? Twittering, what did that mean? Googling, who knows? But these are abbreviations that I've gotten from my own kids and from my medical students and residents. Common expressions, the young people today know what they mean. I don't have any idea. I know OMG is oh my God, laughing out loud, talk to you later, be right back, just kidding. I don't know what SMH is, BAE, what does that mean? Do you know? I don't know either. I love you so much. YOLO, you only live once. FOMO, fear of missing out. AFK, this is a really good, away from my keyboard. Okay, since that's how we communicate. IDK, I don't know. IDC, I don't care. But we need to recapture what we've lost. Patients need us to communicate with them, and we need to communicate in language that they understand. They can't read CT scans. They can't interpret EKGs. And I think doctors also need to communicate better with each other. I'm frequently referred patients. I practice at a tertiary care center. Very complicated patients come to see me. No records have been sent. No phone calls from referring doctors. And I have to figure out why that person is in my exam room with these incredible problems, and there hasn't been any form of communication. That's just bad. It's not good medicine. And I think when you talk about residents and night call, since there's a lot of cross coverage, there has to be perfect communication amongst the house staff. Patients frequently choose their doctor based on his or her ability to communicate, chemistry, emotional attachments, rather than how smart you are or how many diplomas are hanging on your walls. In 30 years, I've never hung a diploma on my wall. I have pictures of Abraham Lincoln and other stuff. A couple of icons. but I don't have any diplomas, and I've never been asked where are my diplomas. I don't think that's terribly important to patients. Do patients want to know the truth? If the diagnosis is terminal, almost all United States patients want full disclosure, and many want to know time estimates. I think it's important for us to remember who our contract is with, our emotional contract. It's not with the insurance company, it's not with the patient's employer, it's not with the family, it's with the patient. And I think we need to remember that. It's also important that we remember if the news is bad, it's not our fault. No, it doesn't mean you need to be cold and insensitive, but just remember that it's the patient who has the disease. This is a picture of Jack Pickleman, sort of an iconic surgeon here in Chicago. He's not practicing anymore. He was at Loyola University. And he was president of this group of surgeons called the Chicago Surgical Society, and we meet once a month and have dinner, and there's presentations. And in his presidential address, he gave the 10 Commandments of surgery. I can't remember all of them, but this one stuck out. Remember, it's the patient who has the disease. And for years, I've been thinking, what did he mean by that? Remember, it's the patient that has the disease. Well, the patient should take ownership. It's their problem. If they have ownership of their illness, it will probably improve compliance to the medical regimen. And I don't think doctors should explain things to the patient as though they're having an internal soliloquy. You know, you shouldn't be talking like, well, we could do radiation, or we could do chemo, and then surgery, or maybe we should do surgery first, and then radiation. You shouldn't talk like that. You should talk to the patient and put it in terms that they understand. It's also important just to be quiet sometimes. You don't have to fill every second of the encounter with your voice. Allow there to be periods of silence so the patient can digest what has been said. And again, if the patient has ownership, it will reduce some of our stress and anxiety. And it's also important to remember you can't make a person feel good about bad news, so don't try to do that. It's not your job to make them feel good. Your job is to inform them and share with them and let them feel badness, let them go through the acceptance process. So, good communication influences patient satisfaction, the quality of the relationship, compliance with medications, outcomes, etc. Now, there's different ways to communicate. One of my favorite movies is The Godfather, and you know there's many different styles of communication in that movie, right? One method is just to put a horse's head in your bed, and you communicate your meaning very well. No words were spoken in this encounter. Or you can shoot down Sonny Corleone at the tollway on the toll road and deliver your message that way. In this encounter, Michael Corleone has just returned from a meeting, and there's Tom Hagen behind him trying to figure out how can he tell him that his wife had a miscarriage and lost the baby. And he can't do it. He's not comfortable doing it. And Michael reaches the point where he yells at Michael and says, "Why can't you tell me what's going on?" We need to do that as healthcare providers. So why can't we? Well, maybe we haven't had the training. Maybe we're not sure whose job it is. Okay, I think if it's bad news, it's the attending's responsibility, not the resident, certainly not the medical student's job. Maybe we don't have time, or maybe we just have a difficulty seeing things from the patient's perception. In this survey from the American Society of Clinical Oncology, less than 10% of respondents had any formal training, and only 32% had an opportunity to watch others do it, shadow them, if you will, while they delivered bad news. This was a study from Baylor, and basically it says that every physician realizes this is an important skill to have, but very few, less than half, get any formal training. And even if you've had formal training, additional training is always helpful. So how can we teach communication skills? Didactics, use of videos, videos watching others, videos of yourself trying to do it in training sessions and then critically going back and watching yourself, small group sessions, simulated patients, shadowing senior physicians. I think that is a highly effective way of learning how to communicate bad news, is watching somebody else who's good do it. Are teaching programs effective? Probably. Are the skills learned retained? We don't know. So how do you measure effectiveness? If your endpoint is, does it reduce the anxiety and stress levels for the doctors? Yes. Does it improve our relationships with the patient? Yes. Does it improve compliance with treatment? Yes. Does it reduce patient anxiety? Not so sure about that, because again, remember, it's bad news that you're delivering. Surgeons frequently are the messenger. In patient surveys, the doctors that have been rated the most helpful in delivering bad news are primary care physicians. Surgeons are the worst. Giving bad news over the telephone or in the recovery room is not good. Patients are likely to rate that as a negative encounter, and the typical encounter for bad news is less than 13 minutes. Why are surgeons so bad? Well, surgeons may be involved at the most anxiety-producing time in that patient's illness. You just made the diagnosis, you did the biopsy, you found cancer, you did the colonoscopy, you found cancer, and you've got to explain that to the patient. And it may be only the first or second encounter that the patient has with that surgeon, but here it is, the surgeon's giving the bad news. The first or second encounter means that you have not had a long-term relationship with that patient. And frequently our encounters are in public places. I know in our endoscopy lab at our hospital, there's not a quiet room where you can pull a patient aside and tell them what the result of the examination was, and that's bad. You know, my veterinarian does a better job than I think we do. I've had to put down several golden retrievers during the course of my life, and the place that I go to has a beautiful room, carpeted, beautiful colors, and you can sit down and hear bad news and hold your animal while they're putting them to sleep. And we don't have that in the hospital. Something's wrong with that situation. So this is probably the most important slide that I'm going to show you. This is a mnemonic for delivering bad news called the SPIKES plan, and you see the references there, SPIKES. Of all of these different steps, I think the setup is the most important. Okay? If you don't have a good setup, the rest of the steps are not going to go well. So S, setting it up. Allowing enough time, get coverage from your partners to allow you to spend some time with the patient and the family where you're not going to be interrupted. Turn off your beeper, turn off your cell phone, pick the right location. Like I said, I remember my encounter with Eugene Sawyer's family in the surgical library. Greet the patient, introduce yourself to the family, turn your beeper off, sit down, make eye contact, ask how the patient is feeling, how's the family doing. Have comfortable chairs. I've walked into offices where there are medical journals stacked on the chairs, a couple of coats draped over the chairs. That delivers a powerful a message. You can come into my office, but you ain't staying long because there's nowhere for you to sit. So this is going to be a short encounter. You don't want to promote that type of message. Avoid barricading yourself behind a desk. Sit side by side or sit at a round table. Patients need to see your face, not your back, which is important, I think, in this era of electronic medical records. So here's not a good office to deliver bad news. First of all, it's not private. There may be another desk on the other side of that bookshelf. Where's the family going to sit? Where's the patient going to sit? So I'm going to move kind of fast through some of these slides for the interest of time. In this era of electronic medical records, it just seemed more personal when I was writing. Now I'm keyboarding. And I tell the patient, you're going to see me typing, but it doesn't mean I'm not listening to you. I'm just trying to keep up with everything that you're saying, because everything that you're saying is important, and I want to capture it. The way my exam rooms are set up in my clinic is the exam table is behind. If I sit at the desk keyboarding, the exam table is behind me, which is not good. I shouldn't have my back to the patient. So before the patient gets on the exam table, they're sitting beside me, side by side. Patient perceptions. Before you give them the news, ask, what do you know about your condition? What is your understanding of what's going on? Because you can't move forward if their understanding is not complete or they have misconceptions. Determine if denial is present. If they're denying that this is all going on, you can't move forward. You also have to determine if they're angry. Because if a patient is angry about either a delay in diagnosis or a misdiagnosis, they have to get over that anger before they can accept what's going on and move forward with an effective plan. Ask the patient if they're ready, and then give a warning shot. I also ask the patient, how do you want me to deliver the news? And I like to use the phrase sugarcoat. Do you want me to sugarcoat things, or do you want me to explain it like it is? And invariably, everybody they just want to hear it. They don't want you to sugarcoat it. Ask the patient if they want the family to be there. This is kind of a sticky situation, especially if the family tells you ahead of time, don't tell what the results of the biopsy are going to show. It's not good. It's not good. If the patient says, tell the kids, whatever you have to say, tell the kids, there's your answer. But if the patient wants full disclosure, you have to do that, because your contract is with the patient, not with the family. The family should get involved in the illness because it allows them to mend fences. You also recruit support for the patient, whether it's emotional, spiritual, physical help, preparation with meals, bathing, laundry, etc. So the more help you have, the better. And I think because of time, I should probably move forward to the last couple of slides. You have to be careful with saying I'm sorry. We're told in this era of being warm and fuzzy and full disclosure, say you're sorry. You have to be careful with that because it might imply you're pitying the patient. You don't want to do that. It might also be perceived as an admission of guilt. Like, I should have read the chest x-ray sooner. I should have ordered a colonoscopy last year. You have to be careful with what I'm sorry means. It also shifts focus away from the patient to the doctor and what the doctor is feeling. And that's not the reason you're meeting. I want to say something about faith, and then I'll finish. You can use your faith to enhance your communication skills. I know it has for me. I think my communication skills have changed drastically since I was ordained. It's relieved my stress and burnout because I no longer feel like I'm alone. And if I anticipate a difficult patient encounter, I'll pray. The Jesus prayer is enough for me to get through anticipated difficult encounters. It also helps me get through life-threatening situations in the operating room. And if we embrace the concept that the Holy Spirit is within all of us, it eliminates internal bias so that when I am talking to somebody, I don't see somebody of a different ethnicity, different race, different gender, different socioeconomic status. I'm looking at a human being who has the Holy Spirit within them, and it helps me communicate, and I think become a better communicant. So with that, I will stop, and I'd be happy to answer any questions at the end. Thank you.
Thank you very much, Dr. Sacclarides. Our next speaker is going to be John Yoon, who's an assistant professor of medicine at the University of Chicago and the assistant program director of the internal medicine residency program there. And he is going to speak on the topic of physician, heal thyself, using life stories to promote physician spiritual well-being. I think this is going to tie in very nicely with what we've just heard.
Indeed. Thank you.
I'll give you a card with one.
Yes, that'd be great. Thank you.
Which is yours, sir?
It's the this one. Yeah. Thank you so much. Sure. Well, hi, I'm John Yoon. I'm a general internist, as was mentioned. And I'm very delighted to have this opportunity to speak before you all today. I was actually invited by Father Elijah Miller in the Hyde Park, the Orthodox Hyde Park Parish. So I don't know if there's anyone who's been there, but he was very gracious of him to invite me to this conference. I entitled this presentation, "Physician Heal Thyself: Using Life Stories to Promote Physician Spiritual Well-Being." And as you may know, there has been increased public attention in recent years to a growing epidemic of physician burnout with an accompanying interest in the well-being of clinicians. And I hope to suggest that the life story approach not only helps us study physician well-being, but also might serve to promote the spiritual dimension of clinicians' well-being altogether. As a Christian medical educator teaching in a predominantly secular context, I have the privilege, through my role in the program on medicine and religion, of interacting with a lot of young, idealistic pre-health students. They're all aspiring to become good clinicians, physicians, many of them. And many of them seeking to do so while drawing from the theological resources of their own religious traditions. It's inspiring to me, actually. But in my conversations, I often discern a common narrative in their struggles to become a good physician, particularly in our contemporary healthcare system. And I'll attempt to articulate this common narrative through a parable that is loosely based on a true story. This is the parable of Dr. Basil, MD, and his life story as a burned-out physician. Once upon a time, there was a young pre-med named Basil Caesarea who wanted to become a good physician. Basil was the son of an immigrant family who settled in the United States. When Basil grew up, his parents were deeply pious and religious individuals, always nudging Basil in one way or another to imitate the saints of old. While growing up, however, Basil often felt the keen distance between his own personal life and that of the exemplars commended to him by his parents. Curiously, Basil also happened to grow up in a cultural context of a community that held the medical profession in complete high esteem. And so all his life, Basil was told tales of role model physicians who viewed their careers as fulfilling a divine calling, medical vocations placed in service of God, and the least of these in society. Indeed, the country where Basil's parents immigrated from was one in which some of her national heroes were actually American missionary physicians. And so before global health became all the rage, these original global health pioneers were motivated by a deep sense of calling, leaving comfortable careers back in the U.S., enduring difficult living conditions as they worked to build up, literally from scratch, the healthcare infrastructure of what at that time was a war-torn, impoverished third world country. So as part of his childhood instruction, Basil was sent on summer trips to the motherland to go on history tours of cemeteries where these American physician heroes were buried in honorable service of his motherland. So very quickly, Basil learned from his parents a very particular, albeit somewhat religiously narrow, vision of what it means to be a good physician. And so the clear parental message was, Basil, if you want to be a good doctor, be like them. Fast forward 15 years later, Dr. Basil is a practicing clinician in a busy tertiary academic medical center, musing wistfully in between frozen sessions of the electronic medical record, and wondering how did he move from the idealism of his early years to the irritating reality of ICD codes, RVUs, ACOs, MOCs, and just the overall accompanying alphabet soup of bureaucratic death. Somehow, over the process of being stuffed with scientific knowledge, randomized control trials, evidence-based guidelines, Dr. Basil feels that along the way, all this science and bureaucratic and economic demands of his profession has crowded out space in his life for simple acts of compassion. Dr. Basil looks around him and feels a sense that something very good is being lost in medicine. He wants to resist the social powers of his age and the forces that seem to be sapping the joy and meaning out of medicine. And as a clinician, Dr. Basil finds it difficult to practice good medicine and be the kind of doctor he wants to be. So he often medicates himself with Korean TV dramas on The Good Doctor. And if you haven't seen this series, Jewel of the Palace, every medical student should review it. So on a deep spiritual level, what is happening to Dr. Basil, the burned-out physician? In any case, I share this parable of Basil, the pre-med, because it's frankly not too dissimilar with my own experience and the experience of physicians around the country. Somewhere over the course of their medical training, a common experience happens to these idealistic students. They become jaded, cynical, discouraged about the meaning of their work. How did we get here? Medical schools are filled each year with idealistic students like Basil, motivated by enthusiasm to live up to the noble ideals of the profession, as well as to live out their faith commitments in their respective Christian communities. Many Christian students, for instance, enter into medicine to live out the compassion of Christ through their work, to grow in holy virtues through their work, and to be good physicians whose faith is thriving in their work. What they don't realize is medical training is also a powerful moral enculturation and formation, and a place of formation, almost a form of discipleship into the culture of medicine. And what is this culture? Students quickly realize the powerful social forces of science and technology, as 90% of their time is studying and imbibing all the fruits of science and technology as applied to health and disease. But when these students also start their clinical rotations, often in complex academic institutions around the country, they also begin to confront another harsh reality to medicine, one that is being driven by powerful market forces and business bottom lines. Not only that, they sense from their frustrated and harried teachers that there are also complex legal and bureaucratic forces that regulate everything, every single thing about their practice. And they begin to see that all these social forces begin to come in the way of a clinician-patient relationship, isolating out space for compassion and holy virtue. In this isolating environment, many are saying are leading to physicians experiencing burnout, as they are asked to work in environments increasingly at odds with their highest moral aspiration and deepest spiritual commitments. And so now you have many increasingly saying that this is not just burnout, this is moral injury. It's a hidden violence to our moral conscience. The healers are slowly becoming wounded, and many years later, physicians often find themselves, if they're reflective about it, needing to get healed from the actual medical training process itself. So back to Dr. Basil, MD. If you accept this narrative diagnosing the condition of modern medicine and how even the healing process, even the training process for young doctors can sort of be a wounding experience of isolation and even violence to their conscience, is there hope for someone like Dr. Basil? Hope for him to be a good physician in the context of a faithful Christian life? So at this point, I'm going to switch gears and share a little bit about a growing field in the psychology literature that focuses on life stories. And I want to share a little bit of research I've done on this topic. And it turns out that a way a person tends to narrate one's life experience offers clues to one's sense of well-being. In the social psychology literature, researchers have found that life stories contain basic narrative sequences that can be analyzed and correlated with measures of psychological well-being. For example, people who tend to narrate life stories using redemption sequences tend to tell stories in which initially bad situations are seen to produce a positive outcome. Interestingly, this research literature suggests that people who narrate their life experiences using redemption sequences tend to be less depressed, less burned out, and more generous toward others. In contrast, people might tend to tell life stories using only what is called contamination sequences. These are narratives in which good situations become spoiled by negative events, like the story I just shared with the parable of Dr. Basil. Research suggests that people who tend to narrate their life experiences using only contamination sequences tend to be more depressed, more burned out, and less generous to others. And as you see on the reference on the bottom of the slide, I'm drawing heavily from the work of Northwestern University psychologist Dan McAdams, an expert in the life story approach to well-being. Dr. McAdams' work provides the theoretical context of the following research questions. Does having a redemptive mindset magnify the positive effects of mentoring relationships on the development of generosity over time in medical trainees? And does having a redemptive mindset protect against the negative effects of neuroticism on the development of burnout over time in medical trainees? So time doesn't permit me to discuss the various theoretical frameworks that explain why we chose to test these correlations, but suffice to say we hypothesized that medical trainees who tended to narrate their own stories using redemptive sequences might also at the same time exhibit personal characteristics that were facilitating their growth in virtues like interpersonal generosity and perhaps protecting them from experiences like burnout. The Project on the Good Physician is a longitudinal study of U.S. medical trainees in the years 2011 and 2012. And you can see we basically surveyed them at different time points during their clinical training. And then at the end, we did some qualitative interviews. And that's where we obtained their life stories. So I'll just skip this method slide, but if those who want to read a little bit more about the methodology, this will be up online. But basically, we did interviews with about 21 medical students across the country and used a life story guide developed by McAdams. So let me just share with you the data. Start on the right side of the panel here. Here I depict the effects of having a positive mentoring relationship on the increase in generosity in the medical trainee over 2 time points with a steeper positive slope, demonstrating a larger increase in generosity as compared with a flatter slope. And as you see, the trainees who narrated their life stories with high redemption sequences that tended to magnify the effect of positive mentoring relationships on a trainee's generosity versus those with a lower redemption. Likewise, if you look on the left side of the panel here, we examined the effects of neuroticism on the development of burnout over 2 time points. And here the steep negative slope demonstrates greater increases in burnout over time, while the flatter slope suggests smaller increases in burnout. And here we see that the trainees who tended to narrate their life stories using fewer redemptive sequences or more contaminating sequences in their life stories, these trainees demonstrated larger increases in burnout over time. And interestingly, those trainees tend to use more redemptive sequences in their life stories, suggesting a protective effect against burnout. This preliminary data suggests that trainees who recount their experiences using a more redemptive mindset might be demonstrating a sort of inner resilience that has a protective effect with regards to burnout. So, in conclusion, the findings of this study underline the importance of a life story approach to studying and promoting spiritual well-being, and this study offers some relatively straightforward educational interventions. For example, cultivating a redemptive mindset in trainees so that they learn to narrate negative events in their training in such a way that they can identify how those events contributed redemptively to their personal growth. And I think this is best taught through role model faculty, as it was mentioned by the previous speaker, who vulnerably and honestly share their own life stories from their medical training, the good, the bad, and the ugly. And especially as these role models describe in their own life how bad events in their own training had contributed to their personal growth in a redemptive fashion. Again, these findings also remind us of St. Basil's admonition to practitioners regarding the purpose of the medical arts, that the medical art is permitted us by God, who orders our whole life, as a pattern for the healing of the soul, that we may be advised to remove what is in excess or to make up what is lacking. Initiatives to reduce burnout should extend beyond the immediate medical school context and invite physicians in training to cultivate a redemptive mindset, learning to narrate negative events during their training as opportunities of spiritual purification, repentance, and a pattern for the healing of the physician's soul. Looking back to St. Basil's ancient monastic healing institutions from previous centuries, Christians in modern medicine need organizations like the Orthodox Christian Association of Medicine, Psychology, and Religion, to create vocational spaces of Christian discipleship for future generations of Christian clinicians. And here they're enabled to reimagine the practice of medicine as a Christian practice of hospitality to the stranger, transformed from simply a marketplace arena of consumeristic exchanges of healthcare services to a space where love can be improvised. And so here the frustrated cry of a jaded medical trainee to a difficult patient, "Oh, Christ, it's you again," might perhaps find healing in a more welcoming cry of faith, "Oh, Christ, it's you again." So for young Christian physicians like Dr. Bezo, I asked them to write out their life stories and to consider ways that they nevertheless saw the hope of Christ in the midst of their journey. And so, how many minutes do I have left? 5. Okay, so I'll share this story that I asked one student to write. And here he writes, for every internal medicine resident, their rotation as a supervising resident in the medical ICU is nothing short of trial by fire. I remember one day during my own month in the ICU, I was caring for a critically ill patient with end-stage kidney disease on dialysis who seemed to be in septic shock. It had been a pretty good day so far, that is until I finally had time in the midst of this day to check the labs of my patient with septic shock. In the heat of the moment, in responding to the patient's critical condition, I had opted to send her down for a CT scan, but I neglected to check her potassium level before doing so. When I looked at her labs, I saw, to my dismay, that her potassium level was critically high. Then almost immediately, I hear on the overhead intercom, "Code blue, CT radiology room," the message indicating that the patient had suffered a cardiac arrest in progress. I rushed down to the CT area to find my intern frantically performing CPR on my patient, who died a short time later. Completely crushed, I found myself in an elevator on the way up to talk to the relatives of the patient who were waiting for me to update them on their loved one's condition. And this was probably when he could have used your talk on delivering bad news. And as my trembling body is rapidly moving up an elevator to face an uncertain judgment, I can only think to myself, this is probably what it feels like to have one's soul lifted up to the throne room of God to face that ultimate judgment day. And in both instances, I have fallen short. Totally crushed, and having oppressive visions of me in a courtroom on trial for medical malpractice, I began rehearsing in my mind a risk management speech to the family. But when faced with all the penetrating looks of every family member, the words I could only manage were, "I'm so sorry, I should have, I thought she was safe to go, there was a mistake, I should have," and then completely lost my professional composure and broke down. After a period of awkward silence, one of the older relatives of the patient gently came up to me with tears in her own eyes. "Doctor, we know you did the best you could. The Lord decided it was time to call her home. We hold nothing against you. You did the best you could, and we thank you for that." Before that moment, I felt my career in medicine was over, the defeat too crushing to overcome, and yet the forgiveness the family showed me was almost otherworldly, breaking into my own broken world of imperfect, burned-out medicine and giving me hope somehow to move forward again. My failure had given way to the good news of unconditional forgiveness. And there, in my suffering and in my predicament, and in the midst of the grieving family members, I encountered Christ reaching out to me with love, forgiveness, and hope to begin again. That was the story. Thank you for your attention. Yes. And I just wanted to share that an upcoming conference on medicine and religion that is actually being led by two Orthodox Christian physician ethicists, Ryan Nash in Ohio State University and Jeffrey Bishop from St. Louis University. So for those who might be interested, feel free to join us.
Excellent, thank you. Well, thank you very much. Our final paper of this session, before we get into our discussion section, is the Medical School Curate, an examination of student need, presented to us by Dr. John Schieffler, who is an assistant professor of health sciences and an adjunct professor of public health at New York University and hails from the Russian Orthodox Cathedral from New York City, New York.
Thank you very much. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Thank you very much for asking me to speak today. I offer for your consideration this morning an idea that might help with both of the presentations that we just saw. Although I work and serve in New York City now, I was born and raised in New Orleans and did most of my training at Tulane University, specifically at Tulane University School of Medicine. And at that time, I had the opportunity to work very closely with a phenomenon that you don't see. In fact, as far as we can tell, it's fairly rare, and that is a chaplain that is specifically dedicated to medical school. Full-time chaplain, clinical chaplain, trained in his art, but is full-time just to deal with medical students and residents. So the title of the work that we did is called The Medical Curate, an Examination of Student Need, and I didn't work on this alone. The chaplain at the time, Dr. Donald Owens, who's since retired, is a cleric of the Episcopal Church. He's also professor of medicine and psychiatry. The other author was Dr. Marc Kahn, who, in addition to being a practicing hemoncologist, is also the Associate Dean of Student Affairs, is still currently at Tulane. So, why is this important? Well, if you haven't noticed, for those of you who haven't gone through it, medical education is rather intense. It's 4 years of postgraduate work, and anywhere from 3 to 7 or 3 to 10, depending upon if you want to really subspecialize, of intense education. It's a lot of stress, okay? And oftentimes, trained and spiritually focused advisors are not available to the medical student population. Now, you might say, well, if it's part of a university, they usually have chaplains on campus. True. But almost universally, they are dedicated to the undergraduate experience. And although they may see graduate students, they rarely enter the medical school campus. You might also argue, well, what about the hospital chaplains? The hospital chaplains, again, are there and can be accessed by medical students on those hospitals that the medical schools are associated with. However, their patient population is generally where they concentrate their efforts. So, as we heard in Dr. Jenkins' talk yesterday, although they are available to staff, it's rare that staff take advantage of it. And arguably, they're not always trained for that population. So, it's important to understand that although chaplains are available to medical students, they often are not trained in the way in which medical education is currently done. It's a different animal. Now, just to give you a concept of what we're talking about, and this comes from the information from the American Association of Medical Colleges, approximately 171 accredited U.S. and Canadian medical schools currently in operation. They're affiliated with over 400 teaching hospitals and health systems, and that includes the Veterans Affairs system here in the United States. So we're talking about over 173,000 full-time physicians, over 129,000 medical residents somewhere in the pipeline, over 89,000 medical students somewhere in the pipeline. All right? This is a huge number of souls, a huge population of people under a very stressful situation, dealing with everything that we just heard, in addition to trying to get an education. Now, one of the topics of this year's conference, of course, is violence. And violence has been the subject of a lot of epidemiological attention lately. And one of the things that is very popular is to treat violence the same way you would a disease. For instance, what we've noticed is that violence spreads from individual to individual and from community to community the same way a disease might. It starts with an individual and then spreads out. If we look at this endemically, we know that communities that are affected with violence, is what the data tells us, also tend to have overlap with mental health burden in that community. They may also have overlap with substance abuse, and you can talk of socioeconomic status and other issues like this. These models can get rather complicated. But the common point, the point at which they intersect, the point at which they overlap is generally contact with the physician. Let's face it, you can go your whole life without having a meaningful conversation with a priest, but try to do that without interacting with a physician. And by the way, I don't recommend that for Orthodox, that they try that. So knowing that, the role of the physician, as both of my fellow presenters have pointed out, becomes so important and such a great opportunity for the communion that we've been talking about, for the reduction of that fragmentation that we've been talking about. But yet, are the physicians themselves in a position to do that? So to understand the role of the chaplain in a medical school, we sort of went to the Western model and this idea of the curate. Now, this definition comes from the Episcopal Church, but I think it fits very nicely. The curate, as it's defined, at least in the Western tradition, is an individual that is officially appointed to act as a representative of and mediator with the divine for a given community in order to support general welfare and collective well-being. This is similar to the little village priest back in Greece or back in Russia, or the Shtetl in the Pale. Someone who knows the community so well. People don't necessarily have to come to them for confession. He already knows their sins, right? As scary as that may be. Now, effectively, this concept of curate becomes a chaplain, quote unquote, based on where they are. So if they're in a hospital or a standing chapel, that generally dictates their chaplaincy. In the medical school, it goes back to its original intent, however, because medical education is so insular. You are marched through from one semester to the next. You have to be. Not to mention the fact that medical school is incredibly competitive. Not just to get into the school, then you have to compete again to get one of the residency slots, of which we have less than we have actually students currently in the system. It's a lot of stress. Okay? So this medical school chaplain becomes not just a spiritual advisor, but a counselor. In the case of Tulane, he was also the ethicist. Also an instructor. And it's an interesting juxtaposition between pedagogy and ethics, because as we know, medical ethics and, for instance, Christian ethics don't necessarily coincide. But the chaplain can help bridge that for those students who may be struggling with that concept. And we know that they do. Okay? By nature, I will point out, however, that the medical school chaplain must be ecumenical, because obviously not all students are going to be of the same faith as the chaplain. But there is a great opportunity for witness if that is done correctly. So, one case study, greatly redacted for HIPAA reasons, but a child presented to the hospital through the ER, had very quote-unquote grave symptoms, turned out to be secondary to acute leukemia. All the standard protocols were followed at the time. The family, of course, insisted on further treatment. The residents said no. They thought it was futile and a waste of time. That was at odds with the attendings. The situation actually got fairly nasty, I'm to understand, very emotionally charged. So they called in the chaplain, because it was basically the last line of defense. Okay? So because the chaplain was also the ethicist, he was able to counsel the nurses and the residents and the attendings about the ethical considerations of what was going on. Okay? He identified the moral implications of treatment, which can get a little touchy sometimes, but he was there at least to be that sounding board. Okay? He effectively became an ethics consult, the ethics liaison, if you will, which most hospitals do not have. Okay? And in this particular situation, a course of treatment was found to be acceptable by all parties for the best possible outcomes. It's important to remember in this situation, the religious preference of the parents did not complicate this situation, so much so we don't even mention it in the article. So, in order for this system to work, okay, the medical chaplain has to be constant. As I said, students are marched through year by year by year. The ability to have the same person in this office over the course of that, say, 4 years of medical education is very important, because the stressors change. As they move from classwork to clinical rotations and then into residency, their dynamics change. Okay? So multiple terms are generally necessary. In the case of Tulane, the chaplain was actually employed by the local Episcopalian diocese. Okay? They actually paid for his time. The reason why this helped is because the chaplain was not necessarily under the jurisdiction of the medical school administration, which means that, and especially as a priest. He did not have to necessarily follow the protocols of the school when it came to reporting. He was often called in as a mediator. So before a student would be necessarily called to the dean's office, he could be called in for the chaplain first. And that actually solved a lot of problems. Obviously, in an educational setting, a terminal degree is preferred. So some activities that the chaplain involved himself with were the same things that medical students deal with. Personal problems, death and dying in the family, relationship problems. Students get married while they're in school. Students get divorced while they're in school, oftentimes when they're residents, actually. And also questions of theology, where that medical issue or that medical clinical protocol is conflicting with their religious beliefs. Okay? He or she actually allows issues to be resolved offline, especially when it deals with interpersonal issues. So if the resident or student is dealing with addiction or substance abuse, it can be handled with the chaplain outside of the normal course of reporting in the medical school. And I've already mentioned the referral before the dean. Okay? Other cases where this was actually carried out, more than one of our students at the time had deaths in the family. This can be very traumatic, obviously, but not as traumatic and potentially career-affecting as if it interrupts a student's education, if they have to sit out a semester. So the chaplain was able to help with that process to actually help the family in the arrangements of time away and how that would affect or mitigate the effect of time away from their rotation and their track. Okay? In other cases, students' parents were divorcing. The chaplain was able to not only help the student understand what was going on, but actually called in the parents. Okay? And, of course, provide a safe space. In some cases, especially if the marriage, if the chaplain is a clergyman, they can perform marriages. Students do fall in love in medical school. They can also help facilitate marriages of other faiths and help arrange all that. They can baptize babies that may be born or arrange it with other faiths. They can perform funerals should the need come and coordinate that with other faiths. More importantly, and I saw this very much in action, unfortunately, is the chaplain was the one who organized the memorials and public events secondary to local disasters. Of course, we had 9/11. Soon after that, in New Orleans, we had Hurricane Katrina. The chaplain was very much a stabilizing factor for many of the students who had to change medical schools in order to stay on their track for at least one semester while we pumped the water out of New Orleans. Okay? Now, the medical school chaplain can provide the spiritual and social supports needed to a community largely underserved. That's the point of this talk. We know, based on the anecdotal evidence that we were able to collect, Tulane University School of Medicine is one of the only schools in the country that has a full-time chaplain. Other schools, some Catholic universities will have chaplaincies devoted to their graduate student populations, but again, rarely are they specifically assigned to medical students. Okay? And it's the focus of this paper that the integration of the chaplain into physician education could potentially influence and guide medical decision-making and care and clearly impact lives. Many of the issues both my previous speakers spoke about, perhaps if the students had time with a chaplain before they got out into the clinical setting, may have made it better. At least we think it can't make it any worse. Thank you very much.
So if I could ask Dr. Yoon and Dr. Saparides to join us by the podium for some question and answer type session. My name is Don Jenkins. I'm a trauma and intensive care surgeon from San Antonio. And my first question that I would ask is to Dr. Saparides. In an era that you so well covered, where we use abbreviations for everything, we also have a tendency to use very colloquial language when we are doing rounding with our teams. and I am quite a stickler for precision in language, and I use some humor to try to help bring that out. And there are times that we'll have a patient that the student or resident will present and say, well, they're wet, so we're giving them some Lasix. And I said, well, why don't you use a towel? Right? They're dry, so we're giving them some fluid. Well, I would put lotion on them if they were dry. Right? So you have to be very precise with your words. But there's some level of interplay between being precise and explaining things to patients and family members in a way that they can understand. And I just wonder if you have any pearls of wisdom that you impart to your residents when teaching them how to deliver bad news in not only a compassionate way, but in a very professional way that can be understood by those patients who are less medically sophisticated, potentially, than those delivering that news.
Well, we actually don't have formal teaching sessions in communication or how to give bad news. I give this lecture once every other year, perhaps, and that's it. And so we suffer from the general lack of teaching communication skills. And but having said that, we have residents and students always in the clinic, so they shadow and they see attendings do it, and hopefully by osmosis they'll learn how to do it. But I think that's we're inadequate in terms of how to teach communication skills.
Yeah, I make a directed point of doing so because I'll witness the resident go into the room after our discussion, and they'll go to the ventilator and start turning some knobs and tell the family that we're fiddling with the ventilator settings. I'm like, we're not fiddling with anything. We're very precisely adjusting the ventilator settings to the patient's precise needs. Those are the words that you say to the family. You don't tell them their loved one's wet, or we're fiddling with something, or we're going to play around with some stuff, these medications. We're not doing any of that stuff. And so I think that there is a way to incorporate that into teaching rounds. It also lends itself to...
I think that over the course of time and with the development of the internet, patients are coming in a lot better informed than they used to be. And the questions are very direct and based on what they have read. And some of what they've read is garbage and not based in science. And you have to sometimes wipe the chalkboard clean as to what their impressions are and start over. But some of the questions I deal with have shown that they've done reading, and you don't need a college diploma to get on the internet and read and learn what does laparoscopy mean, and are you going to do this laparoscopically or open? Are you going to use the whatever technique they might have come across? The laser. And so I think patients are becoming better and better informed, and they're also more informed as a result of some of the garbage that they've read.
Please, if you have a question, come to the microphone so that we can ask those. Please. So that the Ancient Faith Radio is recording, and the answer won't make sense if they don't hear the question.
So my question really is for all three, but essentially there are so many situations where you have to call the patient and explain to them that they need to come in to discuss the test result. And then the first thing they'll say to you is, did the test show this or that? So I'm a provider at a large gay, lesbian, transgendered healthcare facility, and we do HIV testing all the time. So we'll tell them to come in and get their results. Is my HIV test positive? And of course it is, and that's why you're having them come in. I just had a young woman, a woman in her 20s, who I had palpated some lymph nodes in her neck and sent her for a CT scan, calling her to come in for her results. Does it look like cancer? The report said in large letters, probable Hodgkin's disease. And in fact, her biopsy later was Hodgkin's. So how do you deal with that? You want, as a provider, to talk to the patient to come in, but then they ask you a very direct question. And I never lie to a patient, you know, and you were talking about not sugarcoating things, but again, you're faced with doing it over the phone. So how do you handle that?
So, first of all, you should try not to delay in delivering bad news. It should be, I mean, if the reason for your delay is you're uncomfortable doing it, that's not acceptable. It's never going. If you're uncomfortable now, you're going to be uncomfortable in 2 days. So get it done, get it over with. I don't know that I have the answer, and it's something I struggle with a lot. But I just know that some things just need to be said face to face and not over the phone. And especially when you talk about different treatment options, and I draw a lot of pictures for patients when I have my consults with them, and I'll write out algorithms, you know, here are your options and arrows pointing in different directions. Then I give them my drawings for them to take home so that they can look at. And you can't do that over the phone. So if I had to err, I would rather err in terms of a slight delay and being able to more effectively communicate what needs to be said face to face. There's no perfect solution to that dilemma, unfortunately.
I want to thank all three of you for wonderful talks. My question specifically is for Dr. Yoon. I have read that those people who are incarcerated in concentration camps were more likely to survive if they had one particular set of skills than a different cohort of prisoners at a concentration camp. From what I've heard about physician burnout, most strategies are directed to cultivating a survival mindset within a concentration camp. But nobody ever talks about the fact that there shouldn't be such a thing as a concentration camp. What's happened in medicine, at least in the time that I've been in practice, and that's since 95, is that, as Dr. Psychiatry pointed out, there's been an increasing administrative burden. The EMRs have made the practice of medicine incredibly hard. The thing that used to be hard about being a doctor was trying to figure out what to do with your patient. Communication, ordering things, documenting was a no-brainer issue. If you were able to put pen to paper and you were literate, as most physicians are, you could do that with your eyes closed. Now the things that used to be a no-brainer have become incredibly hard. Are you aware of any burnout strategies that actually focus on the cause of the problem? The cause of the problem is not that physicians have a defeatist mindset, although many do, but that they have been put literally into what I would call an electronic concentration camp. And that's really the issue. Thank you.
Thank you. That's a very insightful question. And though I hesitate to compare hospitals to concentration camps, I get your point for sure. Because, that's what students and residents say. Because they actually resist some of these wellness projects and workshops that now medical educators are foisting on our students and residents, saying, exactly what you're saying. Like, okay, you can try to toughen me up in a concentration camp environment, but why not fix the structures? Why do we have to even operate in a system that's can be so dehumanizing at times? And that's why in my one table there, in my one slide, I showed some different social forces. And what that should show us is that to fix medicine is not a matter simply of building inner resilience. I know some Christian theologians talk about some of these social forces becoming kind of modern idolatries of our age, right? When it's loved so much by the system or by the group, it becomes a form of idolatry. And so what do you do when you're embedded in a system of idolatry? I don't have a question. I don't have a great answer to what you do in the sense that, well, what do you do when you're stuck in a power and principality? You pray. We find spaces to pray. We humble ourselves and recognize I can't save myself out of this situation. And I think what is needed are these small, faithful communities of people who just do the basics of let's come together and let's pray for one another. I'll just share one story. When I was in the middle of ICU, I'm in the middle of this whole system. I'm feeling beaten down. I'm feeling burned out. And as the previous speakers mentioned, a medical school chaplain, my pastor noticed I wasn't at church for the last couple of weeks because I was so busy in the ICU taking care of patients. And he called me while I was on call and said, hey, I noticed I haven't seen you in a while. Like, oh, yeah, I know, Pastor. I haven't been in church. I've been busy. And so he says, well, call me when you have a minute during your call time. And whenever things are quiet, just give me a call. And so, I was taking care of my patients. Seems like I had 10 minutes. So I called him and said, okay, I'm coming over right now to your call room, and let's pray. And so that was my worship service for that week. And he was functioning like a medical school chaplain, or in this case, an medical ICU chaplain, right? Sometimes the church has to come into the hospital, right, and be with where the doctors are.
Amen.
So I'm a pediatric intensivist. I've been in academic medicine for 32 years. I love every minute of what I do. I think our students are coming to us incredibly stressed. I'm a mother of a daughter who is in her last year of her undergraduate, waiting to hear if she will even get an interview to a medical school. She's got a second plan. We pray to the hierarchs frequently, the 3 hierarchs, because they're the smartest ones, and they will comfort us. It is unlikely that in medical schools, in my medical school where my practice lies, the focus has become meditation, breathing, not praying, but hiring a chaplain I see in my state institution is unlikely. But I think, and I'd like your opinion, I serve as a informal mentor to some of the young women in our church community who have gone off to medical school or to law school. And I check in on them. I check in on my daughter. I pull them off the ceilings periodically. I send them cookies. But I think my question would be is what is the role of our Orthodox churches in the molding of our young physicians and supporting them? Because were it not that I had a church to go to throughout all of my training, and I chose where I lived, you can't choose where you train because that happens some other way, but I chose where I lived for my practice where I would have a community. So I would really appreciate to know how we can serve in that role until the day when we do have chaplains.
Thank you for your question. The fathers tell us that the greatest evangelical tool we as Orthodox have is by example. And in lieu of a chaplain, I would encourage any parish that knows that they have undergraduates who are going to medical school to make sure that those young men and women get connected to their local Orthodox church, whatever that is. Certainly at Tulane we experienced this. We had a very small number of Orthodox students, but we made sure that they were linked up with the local parish. Even if it wasn't within their jurisdiction, it didn't matter. Somewhere to go, someone to talk to, someone to witness with. Because as you point out, just getting into medical school is stressful enough. The first 2 years is where most people crack, quite frankly, because of the amount of coursework. And that's before they even touch a patient. And it can be very demoralizing. It can be very spiritually dangerous because oftentimes in our human weakness we fall to ways of trying to mitigate that pain, so we fall into addictive behavior and things like this. But the only advice I can offer is make sure that they are connected to their local Orthodox community, wherever that may be, and whoever that may be. they can find a home. And I would also encourage priests who know, because we do this with things like the OCF and undergrad budget, but again, undergraduate bodies, but we don't necessarily address graduate students, and that's what medical students are. But we kind of leave them by the wayside because we're assuming they're mature enough to handle everything. But we don't treat adults that way, so why should we think they are? So that would be my advice.
Hello, and thank you all three of you for your presentations. I wanted to ask Dr. Yoon in particular, or anyone who has thoughts, for I think really all of us here who are in fields or going into fields with a high risk of burnout. Did you gather from the quantitative or the qualitative aspects of your interviews any insights as to how we can foster within ourselves this more redemptive mindset, or how, if we're ever in a position where we're mentoring or serving as a chaplain over people going through this, how we can help guide other people to that more of that mindset as opposed to contaminating mindset.
I think that, first of all, let me just back up a second. I think, Father, what you said about OCF chapters being prevalent in undergraduate campuses, but hard to find in medical campuses is so true. And I think there has to be a designated parish for the medical district in whatever city you're in. There needs to be dedicated clergy to sponsor and host the meetings. It should be open for attending students, nurses, anybody involved in healthcare. Trying to remember the question. Oh, I draw my own belief from something I read written on the wall of the cafeteria at Loyola University. I was on staff there for 5 years before I went to Rush. And Loyola is a faith-based institution. But one of the best ways to forget about your own woes is to immerse yourself into the woes of others and care for others. So I would tell medical students to volunteer at free clinics, to get involved in helping the underserved, and dedicate time and efforts to those less fortunate than yourselves. And sometimes your own problems don't seem as significant anymore.
I think that each of you has mentioned a concept of sort of leading by example. And another thing that I do with regularity, almost planned. I don't put it on the calendar, but there's not a week that goes by that I don't call one of my residents or one of my former residents who's out in practice now to ask how they're doing, or to do the unthinkable as a surgeon, which is to tell the resident they did a good job that day. And that although you struggled with this thing, let me take this teachable moment to talk you through that thing. And I think that over the course of time, that's another way for us, as you just stated, to get inside the woes of others. Because the burnout issue is a real problem. So much of that comes from family pressure. So much of that comes from relationship pressures, having nothing to do with what's happening in that training paradigm, which is what your ID badge says you're there to do. And I think that stepping back from that, inviting residents and students to some sort of just simple social gathering to get to know them outside of that sterile workplace is another great way of not only being, practicing hospitality, but also setting by an example.
And I was going to share exactly the same thing. There's this term called interpersonal coping mechanism of role modeling. And the idea that you find a role model who you're able to go to, and that relationship itself with the role model is a coping mechanism of dealing with some of the stressors that happen during medical training and burnout, right? And so this counsel to join community, particularly when students are choosing different schools, okay, you got into different medical schools, and they're thinking, which medical school should I go to, professor? And I first say, well, I would rather you ask a different question first. Which community are you going to choose? And then choose your medical school, because it's going to be the community that's going to be supporting you, and so I fully agree. The idea of, let's say you're in a medical place where maybe that's where you happen to get in and you don't have any, but I believe there's always one or two folks there, like sort of the remnant of the faithful who are there. In some ways, they were meant there to be there for you. And sometimes my role is, in many ways, I meet Orthodox Christian medical students all the time. And I say, hey, there is this professor, you should get to know them, meet them. And I sometimes just feed students to different people, My own mentor was Catholic, and I'm not Catholic, but he spent time listening to me venting about what I was going through. And just that venting process and just getting wisdom and seeing his own life of how he organized his academic career with balance, that itself was a way for me to cope through and also inspire me through times of burnout. So I would just definitely.
Hello, I'm Cassie. I'm a critical care nurse, and I just was thinking about, I think it was a story that you told about times I've seen residents and nurses make mistakes. For example, a patient arrests because we're bagging them without the oxygen on, or her patient bleeds out shortly after taking like a dialysis catheter out and no one checked it, and different things like that. Or most recently, it's been very common to have very verbally aggressive families coming at medical professionals. And we've really tried to start doing things like real-time debriefing within the unit, and I was just wondering what your experience is with that. I've actually read some articles on surgery specifically. I work in the medical side, but the numbers of like alcoholism and just self-medicating of surgeons. And it seems like there's a difference in what surgeons want for their debrief. Some say they only want other surgeons. Some say they want like a social worker to come in and debrief with them. And I was just curious what your all personal experience has been with debriefing Sentinel events.
I've never had a complication, so I wouldn't.
But you witnessed others.
Right. I don't know that I've ever been in a debriefing session. I've always had to give bad news on my own, and my policy has been honesty is the best policy, and just say exactly what happened, and because I feel like I have to live with myself afterwards, and I don't want to live in illusion, and so I can exist better if I give full disclosure. And what's your daughter's name, by the way?
Mine?
Yeah. Constance. Let's all pray for Constance, because she will get into medical school, right? All right. So, so that's my answer. I think the concept is great, but I just can't say that I have a vast experience in that whole thing.
So I do real-time debriefings all the time, and in what we do, if you're in the trauma room for 15 minutes, you're probably in there 5 minutes too long. And so there's a lot of activity, a lot of life-saving interventions within a very short amount of time. And if you put things in the wrong sequence, it can cost time, blood, life in those folks. And that team that comes together has thoughts and feelings about what has been transpiring, what just transpired. And just the mere acknowledgement that you would be willing to say, hey guys, what'd you think about that resuscitation we just ran? Do you think there's anything we could have done better? And then they'll start to, well, I should have done this thing, and I didn't think we were moving fast enough, and. Then I'll point out that, by the clock, you intubated the patient, you gave them antibiotics, We packed their wound, we put in a chest tube, and we took them to CT scan. We did that in 9 minutes. I'd say that's moving pretty fast, and I don't disagree that we could have done something better. What could we do differently about that so that thing doesn't happen again the next time to someone else or to you? I debrief at the end of every operation. I ask the scrub tech, what should we have done differently to make this more efficient, to make this better? Because I don't want any hierarchy. I want people to come to me, tell me the truth every time. When there's a problem, I want to know about it. Because if you're in an environment where people are afraid to talk to you, then they aren't going to tell you the problems and the things that you need to fix. So I'm a real believer in real-time debriefing.
Does your institution have Schwartz rounds? No. Okay. Some institutions have what's called Schwartz rounds. It's led by social workers or chaplains, and they create these spaces where clinicians can just honestly talk about their experiences, sometimes troubling experiences that they've had. But I don't think that you don't need a formal Schwartz rounds. I think you can even talk to a supervisor and say, hey, I think it would be really helpful once a month to debrief over lunch over things that had occurred in the unit that might be bothering folks. So.
We do have a weekly conference in our department called Morbidity and Mortality, M&M, which is kind of a debriefing. So every complication is discussed, and it's graded. Is this an error in technique, an error in judgment, a delay in diagnosis? And the whole department discusses it. But it's confined to surgeons. There are no hospital administrators, just surgeons. And every complication is discussed. You got to be careful how you conduct those things because it can turn into sort of vigilante sessions sometimes. And the skill of the moderator is very important in terms of making it a teaching session and not a vindictive session.
So one of the other things I'll do, especially when it comes down to decision-making or technical difficulties that a resident is having. I recall a particular incident where an older woman involved in a car crash unfortunately arrived with CPR in progress. And we ran a resuscitation on her as one would with intubation and infusing blood and blood products and placing chest tubes, etc. And unfortunately, her neurologic exam showed no signs of life. There was no cardiac signs of life. And the resident who was running the resuscitation, I could sense, was quite reluctant to be the person to say, we're done. And so in lieu of that, that resident would ask the room, is there anything that anyone else can think to do? And so then I begin to recite. So you have no cardiac activity, you have no respiratory activity, you have no neurologic signs of life, and you have done this, 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 and this. Yes. Does anyone have anything else we could do? And I let him go through that because this was a real teachable moment. 3 times before he finally said, well, I guess that's all we can do, and that that resident had never had to do that before. Now I let that sit for about 45 minutes with him so that he could think through this thing, and then I called him and said, I'd like to meet with you and have a conversation. And so we sat down in the hospital cafeteria, and I said, how did you think things went in that resuscitation? I couldn't say she was dead. Like, I know. Now let's talk through that. What caused that in you and. So again, a different kind of a debriefing where you let someone think about it for a while so that they can try to come to terms with it themselves instead of force feeding them ideas and then they just like leave it at that. And they never did the introspection part.
Sorry, that affected me a little bit. So now my technical question is going to be affected by the emotions and responding to your story. I guess it ties in a little bit. My question was regarding Dr. Yoon's word of the remnant, and that word kept bouncing around in my head where, there's a sense of loneliness as a practitioner who cares about these things. And then coming to a conference like this you feel rejuvenated a little bit. It's like, okay, like I'm not the only one thinking about these things, caring about these things. But at what point do we say, okay, we've done all that we can? Because there is a desire to operationalize this, right? There is a desire to generalize it so that instead of suffering at the micro level in a broken system, part of our mission, part of our goal, part of being ethical providers is to say, okay, what can be done on the macro level? Yeah. So without being political and without being overly zealous and without saying, oh, we're going to go save the world. But maybe what are some practical things that you would recommend so that maybe it's not a remnant, maybe it's not just here's what we're doing day to day. Do you have any advice, and this is for all the speakers or anybody else in the room that has a shared vision on how to do something more before we get to that point where we said, okay, like that's it, and let's just accept the remnant. Let's just accept the effect that we have on the micro level. What else can we do on a macro level so that this isn't so strange and so restricted just to a medical conference like this? Well,
what I meant by remnant wasn't necessarily sort of a call to withdraw from the system and just sort of hide out in a religious enclave waiting for the world to end kind of thing. What I did mean by remnant was that we do need a space of refuge for the faithful to be rejuvenated, to pray, to experience the presence of Christ and the encouragement of the brothers and sisters. We do need that, right? So that then we have the strength to move out in mission, right? And that could be different from different people, but some might be called to change the social structures that are causing some of the large macro issues, right? You're in public health, so you're in many ways dealing with more of the social, larger things. For me, I find myself called more to be with sort of the students on a one-on-one basis, while alerting them to some of these things that they're experiencing, right? Even though I don't have particular levers of power that I'm wielding right now that can actually affect change yet. Maybe when I become a chairman or a dean someday. But, in any case, but I think given what you have right now, what God has given you, what can I do in mission to begin changing some of these things? So I'm not counseling, just hang out and huddle in a holy huddle with your remnant. But you do need that for your support. Otherwise, when you're out there fighting the good fight, how long can you fight without the community? So that just to clarify, that's what I meant. And so, if you're out there changing structures, God bless you. We should be praying. The whole church should be praying for the social structures to be changed.
So, for the final question, and I would ask each of our presenters to give me your thoughts on this. I don't recall seeing this or hearing this in any of the presentations. Might have been in there, and I just wasn't paying enough attention. But when we're talking about wellness of physicians, trainees of any kind, of our coworkers and colleagues, there are a lot of nonverbal cues that lend themselves to identifying that someone is having an issue. And I wonder if that's something that you teach to people, or things that you have picked up on your own. Very commonly, when a resident is not performing to a standard that's expected, my partners will say, "What's wrong with John?" And I'll say, "What's wrong with John? We should go find out." Because more often than not, it's not a technical skill problem. It's just lost their dog. Right? I mean, so nonverbal cues. Can you address that and how you identify people or...
I think the identification process should start before the student or the resident comes to your program. And I think that it's important for students to be in an environment where they have a support system in place, family members in town, for example, to have a spouse. If they have functioned as an athlete, especially in a team sport, I think is a positive thing that we've noticed in the application process. If they've served in the military is another positive thing in the application process. Once they start at your institution, I think there are red flags that should be identified early. And one very important one that not many people talk about is how does the student or the resident treat those who are junior to them, the third or fourth year medical student? How do they treat the first, second, and third year students? Are they nice to them? Do they go out of their way to teach? How does the resident and the student deal with nurses? And are they nice with the nurses? Those people who don't work well in a team environment, I think it's a red flag, and that person should be taken aside and find out what's going on. If there's a resident in the program that the holidays are coming up and they have no family in town and no spouse, and if they're an intern, they may not have had the time to develop friendships and they're all by themselves, I think we as faculty should go out of our way to have them over to our house or make sure that they have somewhere to spend the holidays with.
My last year in Rochester, a couple of years ago, we had 80 residents and their family members in our house for exactly that same reason. It teaches hospitality, sets the example. And getting to know these people is the only way you're going to figure out about these cues. Anger is another one that comes out, etc. So for those of you that missed the announcement, the final wrap-up session for today is going to be here, not up in the nave. There's a little bit of a break, and then the final paper session. Thank you. Thanks to our speakers.